Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled Pharmacy's Call to Action, Achieving Pharmacoequity, Focus on Cardiovascular Disease. We are thrilled to have Dr. Kimberly Zammit as our guest who will present. Dr. Zammit received her BS, Doctor of Pharmacy, and Master's of Public Health degrees from the University at Buffalo and completed an ASHP accredited hospital pharmacy residency at Buffalo General Hospital. Her pharmacy practice experiences are quite diverse and include community, home care, industry, and health systems. In her current role at Mount Sinai, she is the Executive Director for Clinical Pharmacy Services, where she oversees formulary, policy, practice, research, and education for the health system. She holds board certifications in pharmacotherapy and critical care pharmacy through the Board of Pharmacy Specialties. She is adjunct assistant professor for the University at Buffalo School of Pharmacy and a member of the university's Institutional Review Board. Her leadership activities include service as president and on the board of directors for the New York State Council of Health System Pharmacists and a past member of the New York State Board of Pharmacy. In 2009, she was named Fellow of American Society of Health System Pharmacists. She is also the recipient of the University at Buffalo's Willis G. Gregory Award and the New York State Council Bernard Mell Leadership Award. Before we get started, I'd like to share some quick points. For those who have technical issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that would like to be directed to the speaker, please use the question box or chat option. The CE codes for this program will be provided at the end of the program. And now I'd like to turn it over to Dr. Zammit.
Okay, thank you very much, Kelsey. And thank you everyone for getting on this afternoon. I'm so excited to be able to have this conversation with all of you around pharmacoequity, where pharmacy sits with all of this, and in particular, how this plays into the management of cardiovascular disease. So here are learning objectives, and while you're reviewing those, I also want to make mention that I have nothing to disclose by way of this particular topic. So why are we talking about health disparities in cardiovascular disease? And I do want to make you aware that we received a grant from Janssen before they were changed their name and are now officially part of J&J. But we received this grant to provide education as well as to support our own grant process, which we'll talk about at the very end of this talk, around achieving pharmacoequity in patients who have cardiovascular disease. And the other reason, aside from the grant requirements, that this is so important is that the leading cause of mortality in the United States is related to cardiovascular disease. And then if we add stroke to that, we can see that we're pretty much pushing 1 million deaths a year from cardiovascular disease and stroke. And so there's an awful lot of opportunity in both of those areas for pharmacists to be involved in disease and drug management. And so that really aligns with what our mission is as pharmacists, as well as the fact that, of course, it aligns with what the requirements will be for the grant. So what is pharmacoequity? And this was a term that was first coined by Dr. Udeby Eisen in JAMA in 2021. And pharmacoequity really relates to all patients having access to the best quality, evidence-based medical treatments, regardless of their race, their socioeconomic status or class, their age, their sex, or the availability of resources. And so we'll talk about what all the factors are that really impact pharmacoequity, but the goal is to achieve pharmacoequity as the end result of healthcare and that to remove those disparities and overall improve patient outcomes. And although not all patient outcomes are related to drug-related treatments, Certainly many of them are. And understanding that not all patients have the same opportunity to achieve those outcomes is really what pharmacoequity is all about. So those factors that impact the social determinants, or I'm sorry, the ability to achieve pharmacoequity are called the social determinants of health. And I'm certain that you all have seen this on numerous occasions. This is a graphic from the CDC that allows us to easily see that it's not just healthcare access and quality that influences health, but it's patient or person's education and their access to quality education, economic stability, being employed, and having not only being employed, but not being underemployed. So having an adequate salary to support themselves and their family, a neighborhood and built environment that is safe and allows them to live in a stress-free environment, and also affords them opportunity to get physical activity. And then social and community context, which is really probably one of the big reasons why we saw a lot of issues during COVID, not just in patients with health disparities, but across the healthcare continuum, is that we realized that the social network is so important for all of us, but is even more important for patients who have other health disparities. And so if we put this into a graphic that allows us to see how those factors impact the different aspects of a patient's life, you can see a little bit more detail here. So under economic stability, we talked about that already, but it also relates to whether or not patients own their own homes, or if they're able to even receive financial assistance for housing. The built environment relates to housing security, as well as from a homelessness standpoint, as well as what the neighborhood is like, violence and crime, and also relates to food security. And food insecurity is a big issue from the built environment standpoint, as well as geographic standpoint, and the prevalence and availability of foods that are actually healthy in one's neighborhood. We talked about education and a little bit about social community context, but that social cohesion, especially for neighborhoods and for groups that have been marginalized, and to have that social support is really important. And then there's the healthcare system, which we're really going to talk about in a lot more detail, but it's, the provider bias, implicit bias, institutional racism or structural racism. You'll hear both of those terms used interchangeably. The ability to communicate and making sure that we're all culturally competent. And then trust, not listed here, but trust is also a very big component of where the determinants of health outcomes lie. And so again, how those upstream determinants will relate to the factors that impact health are shown for you here. And so I won't go through all of them, but you can clearly see that there are multiple factors that these determinants influence, the least of which is not psychological and physical stress, unhealthy behaviors, physical inactivity, lack of support or good diet. And then again, racism, the perception of racism, and mistrust by patients towards the healthcare system. And so if we put all of these things together, this increases the risk of cardiovascular diseases, as listed there. And really, you ask yourself, well, what is the theory? What are the reasons why this would actually develop into cardiovascular disease? And the data is really pretty consistently showing that there's increased rates of the various hypertension, heart failure, stroke, diabetes, all of these things have a higher incidence in patients who have a high burden of health disparities. So what is the biologic plausibility of that? And you can see in this graphic that very nicely lays out for us what is happening. And so all of these psychosocial and environmental stresses lead to separate pathways that promote chronic inflammation. And chronic inflammation, as we've all learned, is one of the pathophysiologic bases of cardiovascular disease and progression. It induces obesity, it worsens hypertension, it induces especially type 2 diabetes, and then all of those things interplay to produce atherosclerosis, and then, of course, major cardiovascular outcomes. So really, the whole point of this is that if we can hit some of these factors from an upstream perspective, so in the very beginning, addressing those social determinants of health, then that won't translate into those midstream and downstream determinants, which ultimately is the progression of disease. So all these factors then interplay together to impact the ability of pharmacists or of patients to achieve pharmacotherapy or pharmacoequity. And pharmacists, by way of multiple different pathways, can influence each one of these to help patients achieve pharmacoequity. So it really is not just about choosing the right drug for a patient, but by understanding how all of these factors influence any given patient at any given time and what needs to be done to address those factors and improve patient care. So breaking down the social determinants in a different way and categorizing them a little bit differently, we can now look specifically at what those patient factors are that we can be thinking about when we're reviewing our patients. And for me, the thing that probably jumps out the most here are two things, and not that we don't need to understand all of them, but definitely trust in the healthcare team and the ability to communicate well with patients, I think, are really critically important. And if we look at this data from the Kaiser Family Foundation, and if you're not familiar with the Kaiser Family Foundation, I would really urge you to go on to their website and review the plethora of data they have around all types of issues related to healthcare, but specifically there is a wealth of data around health disparity and statistics and some discussions around solutions to improve health disparities. So this is from a survey that they did in 2013. And one of the questions, some of the questions they asked were really around discrimination in healthcare. And you can see here that it's certainly for Black patients, they were almost twice as likely as white patients to feel they were being treated unfairly or with disrespect. But also for American Indians and Alaskan Natives, that was also significantly higher. So also not as significant, but certainly greater in Hispanic patients as well. So really being, I think, aware of the fact that you don't want to make patients feel like they need to know something because they're ignorant, but rather you need to help them understand what they need to know because you're trying to help them. And I think being genuine in that regard can certainly address patients and help patients feel as though they're not being discriminated against. The other thing that's that are big factors when it comes to pharmacoequity are related to our healthcare system. And there are certainly multiple things that we can do as pharmacists, and I'll talk in a little bit more detail about that in a minute. But I do want to spend a little bit of time talking about implicit bias. And I'm certainly not an expert in this area, but it behooves all of us to think twice about the judgments that we're making about patients that we see. And we hear others make comments, and sometimes our bias may be overt in that we know that it's happening. We see patients that have disease states that we feel are mostly because of their lifestyle and their choices that we've made. And we may not be giving them the same consideration that we would other patients who we're not making those decisions about. But then there's something that's even more difficult to understand, and that's implicit bias. And that's related to things that we don't necessarily know that we're utilizing to make decisions about patients. And so, I think many of us have always used the mother analogy. And although I don't profess to say that this is a panacea for solving that problem of implicit bias, but it's been my own personal way of ensuring that the decisions that I'm making, the way that I'm viewing the patient, are without those judgments or those feelings that we have that are very deep-seated, that we don't necessarily bring to the forefront. And that is, pretend like it's your mother or your father or your loved one in that bed. And what would you want done, and how would you want that person treated? There may be other ideas and ways that people address what implicit bias might be. And I think maybe just the first piece of it is understanding that no matter how good or kind you are, it's not about that, but it's about, what your lived experiences are and how you bring those lived experiences to the decisions that you're making. And really try to understand that you need to put yourself in the place of that person and not necessarily think about things in the way you would want them done, but think about things in the way that that individual might want them done. So sorry, I probably got a little preachy there, and I apologize for that, but I think it's really a big thing for us to be cognizant of. Geographic access, certainly that's an issue, and we're going to talk a little bit about transportation and pharmacy deserts in a minute. I think staff diversity is huge. Patients want to speak to people that look like them, that can relate to them. And one of the things I think that pharmacy is doing that is really wonderful around this is trying to improve the diversity of our workforce. And I think that will certainly go a long way to help us in addressing this particular piece of pharmacoequity. Research, we'll talk about that too, where some of the pitfalls with research are and how that really impacts the ability of patients to achieve pharmacoequity. And then finally, there's quality of care. And we know that patients with health disparities are often less likely to achieve the same quality of care than patients that don't carry a high burden of disparity. So one of the places where this is really pretty important to point out is in the treatment of atrial fibrillation, as well as in the prevalence of stroke. And I understand that not all strokes are related to atrial fibrillation, but both of these disease states I think are important. It's important to understand that they're preventable, and the consequences of having a stroke can really be significantly life-changing. So although mortality is an important endpoint when it comes to stroke, certainly chronic disability that stroke can create is very significant. And so when we look at the statistics around stroke, it really is striking. So African Americans are 50% more likely to have a stroke than white adults are. And Black men are 70% more likely to die from a stroke. Black women are more likely to experience strokes and stroke-related deaths at a younger age. And we certainly saw this gap worsened during the pandemic by almost 25%. And the incidence, and that's stroke all taken together. So that's all potential reasons for stroke. But then if we zero in on atrial fibrillation, we know that the incidence and prevalence is lower in minority populations, but maybe that's likely because they're less likely to be diagnosed with atrial fibrillation, and that really has to do with touch points within the healthcare system. And they're also more likely to be undertreated. So obviously, non-treated atrial fibrillation, depending on what your CHA2DS2 score looks like, can have a significant impact on your risk for stroke. And overall, minority populations have more severe thrombotic events and have a higher mortality than their white counterparts. And if we just look at this in a graphical depiction, we can see that when it comes to outcomes from atrial fibrillation, Black patients relative to white patients are higher risk of death, developing stroke, and also for hospitalization for heart failure. So I'll talk a little bit more about heart failure as well, but many of the consequences of atrial fibrillation are magnified in patients who are African American. And so the next two studies were conducted at the VA and are interesting. They were led by Dr. Eisen, and I bring him up again because you'll find out a little bit later in the presentation that he's actually going to be part of our speaker series around pharmacoequity. And so I think one of the things that he was very passionate about, of course, is the adequate treatment of atrial fibrillation in patients with racial differences. And so you can see here in patients who have atrial fibrillation, so this is really all comers, and depending on their CHA2DS2 score, you have a graph on the left, which is a bit CHA2DS2 less than 2, and then on the right is greater than or equal to 2. And you can see that the likelihood of patients receiving a DOAC in either situation is greater for patients who are white than those who are Black. And certainly we all know that the better treatment, right, for patients with atrial fibrillation is a DOAC. And so that was with all comers. And then this study was actually followed up by a second study that looked at incident atrial fibrillation and the likelihood of prescribing a DOAC. So you can see, again, in comparison to white patients, Black and Hispanic patients were much less likely to receive DOAC therapy. And so taken together, this suggests that there may be factors that are causing providers to be less likely to prescribe a DOAC in these populations. And one of the suppositions, of course, is that because this is a population in the VA, which really where insurance coverage may not be the thing that's the barrier to care, that the supposition is that there may be some implicit bias that's driving this. And so the good news is maybe it's not all bad. And so this is actually a study that was just published in May that looked at use of oral anticoagulants in a population of Medicare patients. Now, granted, this is much more heterogeneous in terms of their the potential factors that are impacting prescribing for them. But you can see here that the gap seems to be closing. So if you look at, for instance, in the top left graph, that is warfarin prescribing over the course of time from 2010 to 2019. So in the beginning, when DOACs were first introduced onto the market, you can see that for this population of patients, which is a cohort of greater than 65 years, So a little bit different than the previous population. There was still a gap between Black patients and white and Hispanic patients. And you can see so more patients were prescribed warfarin and less patients were prescribed any of the DOACs. But since time has gone on, that gap seems to have closed. And now it's seems much more likely that Black patients will, or Hispanic patients will receive a DOAC. But you can also see here that the number of patients percentage-wise that were studied was significantly less than what the percentage of Blacks would be in the population. So whether or not this is completely generalizable it is a matter of debate, and it still may not tell us what this looks like for patients who are not Medicare fee-for-service and enrolled in a Part D plan. When it comes to mortality, it doesn't really matter what the cause of the cardiovascular disease is, or the manifestation of the cardiovascular diseases. Mortality is higher in Black patients than it is in white or non-Hispanic white patients. Although the rates of cardiovascular death have decreased, so this is over a period of time out to 2019. So over the course of 20 years, you can see that the number of deaths per 100,000 population has decreased substantially, but that gap really has not seemed to change a whole lot between Black patients and white patients. And they're 30% more, not only are they 30% more likely to die, but they're much more likely to have hypertension. And women are 50% more likely to have high blood pressure. And what this translates into often is heart failure. And there really is a plethora of data around health disparities in heart failure, and really across multiple racial and ethnic groups. Mortality for heart failure is higher, as well as the ability to achieve guideline-directed medical therapy, and then to accept therapies like LVADs and certainly transplants. So again, whether or not this really relates to one particular factor is unlikely. And if you think about all of the factors that go into driving health disparities, there's multiple different places that we as pharmacists, as well as the entire healthcare system, can have an impact on these outcomes. And then finally, I didn't want us to forget about patients that live in rural areas, historically considered an underserved population, particularly in the South, of course, where the percentage of minority patients is much greater. There's always been an appreciation, and you can see here that the increase in mortality, that those graphs start to separate sometime in the late 1980s. So I think the reason this is important for us is that although not everyone in New York and not everyone that belongs to the New York State Council lives in a rural area or sees patients from a rural area, I think many of us do. And those even in urban centers who get referrals for patients that live in rural areas, it's important to understand that just by virtue of your geography, there's an excess mortality. And this is not just from stroke and cardiovascular disease, but also there's higher maternal mortality. And of course, that's something that's gotten a lot of attention as well. So there's a lot around social policies that need to be changed in order for us to address pharmacoequity. I think from a pharmacy perspective, certainly becoming part of the advocacy effort. And when I say advocacy for pharmacoequity, it's really being part of the advocacy for social justice in general, because many of these things are, of course, beyond our control as pharmacists and the pharmacy profession, but certainly adding our voices to those discussions and the experiences that we have taking care of patients who have these issues is very important. I'll just share a quick story with you. So despite the fact that I'm full-time at Mount Sinai, I still spend some time on my weekends working at my old hospital, Buffalo General, in the ICU. And as part of that, medication history taking, of course, is essential. And I don't know, about a month or so ago, I had a lady and she'd been admitted for GI bleeding, but her anti-epileptics could not be verified. She was on 5 different agents, was seen by an epileptologist, and this was all related to a traumatic brain injury she had many, many, many years before. But in the process of trying to determine what she was actually taking, and one of those drugs was lamotrigine, so it felt actually pretty imperative that I get it right. I came to find out that not only 1, but 2 of her pharmacies had closed in the previous 3 months. And she was having trouble trying to figure out just where to get her medications filled from. And it wasn't like she was alone in life. She had a very loving family who were equally as frustrated by not being able to find a pharmacy that could bring the medications to her. So to me, it's a real life example of, how we can identify these problems and really go the extra mile to try to help patients. Even though we're not necessarily in the community setting, we can certainly help bridge that gap and help her find that and solve that problem, even though that wasn't why she was in the hospital. Certainly, we didn't want her to have a bad outcome related to her anti-epileptics while she was there, but also wanted to make sure that when we sent her home, we were doing the right thing as well. Okay, so I'm not going to read through everything on this slide because it may be a little, it's not really necessary. What I really want to point out to you is that there are multiple case series where it's been demonstrated that when patients have transportation barriers, it is much less likely for them to get their prescriptions filled, which is exactly what happened to that lady that I was telling you about. And, not just epilepsy, certainly, diabetic ketoacidosis, which many of us are familiar with, the issues that patients have with access to insulin and taking their insulin and how that often drives that disease state. But really, by and large, regardless of what their diagnosis is, anytime a patient has difficulty getting to a pharmacy, they're less likely to fill medications. And the highest rate of primary medication non-adherence, which is the filling of a first prescription, is much higher in areas that are poverty-stricken or areas where there's less likelihood for individuals to have a vehicle. So knowing whether or not your patient has transportation and where they go to their pharmacy, I think is going to become even more crucial. And as the pharmacy deserts continue to grow. So there was a statistic, and I'm going to mess this up, but it was something of the neighborhood of 90% of people live within 5 miles of a pharmacy or something along those lines. And anybody that wants to correct me, please throw it in the chat. But that statistic is no longer relevant. And the thing, though, that's really disturbing about what's currently happening is that where these closures are happening are in areas that are less affluent. So the poorer the neighborhoods, the more likely that these retail pharmacies are closing. And here, this is a picture of there being some some patients that are upset about a Walgreens closing, but it's really not just chain pharmacies. It's often independent pharmacies that are closing too, and there's other reasons why they're closing. But in many places, they were the only individuals that were willing to go into those poverty-stricken communities. So now you have the double-edged sword. You have community independent pharmacies that have been struggling to stay afloat for some time, who may not be able to continue in areas that don't have a lot of pharmacy services. And then the double whammy becomes that the contraction of the chains is also taking place in these areas. Again, just another thing for us to be very cognizant of. And then certainly when it comes to health policy, this is another place that we can advocate for. Reform around insurance coverage and drug pricing, of course, gets a lot of attention, but also drug development and research regulation needs improvement in terms of pharmacoequity. And I'll go into that a little bit more on this slide. So a couple of things. The first is that we know that Black and Latinx patients are less likely to be included in clinical trials. That is phase 3 clinical trials. So landmark pinnacle studies evaluating the efficacy and safety of a drug for a particular indication. What's really interesting about this is that they are more likely to be represented in phase 1 or phase 2 trials. So areas where there may not be any likelihood of benefit, there's overrepresentation, and areas where there could be benefit, or where the ultimate knowledge that's gained by understanding the impact of those therapies on different racial and ethnic groups is they're underrepresented. So the FDA and the NIH, as you can see here, they have a grid here that talks about levels of influence and how those levels of influence can be applied to a research framework, and also included in not just certainly clinical trials of drugs, but across the spectrum of research around health disparities, what really needs to be done. And you can see how complex a thing this is going to be to get our arms around. But really, the guidance that's been established around definitive clinical trials by both the NIH and the FDA is really not very enforceable. So it hasn't had a very big impact on the recruitment of patients who are of racial and ethnic diversity into clinical trials. And certainly some of it are investigator recruitment, but also this goes back to trust. And, pretty much every time you hear a talk about the underrepresentation of ethnic and racial groups in clinical trials, people will talk about the Tuskegee experiments. And I don't really have to go explain that to all of you, but certainly, that really came back into the forefront in the last several years, particularly around COVID, and then again around the vaccines. And that has, I think, contributed to the fact that we don't have patients being enrolled in clinical trials at the rate that they should be in order for us to understand the impact of therapies. And then finally, as I mentioned, there are so many determinants and factors that have yet to be fully elucidated. And we need to do both quantitative and qualitative research in order to understand things better. We need to go back to the basics in some respects and really make sure that patients are being identified appropriately based on their race and ethnicity, and to be screened thoroughly for social determinants of health that can be impacted. And having that information available as part of the medical record going forward I think is going to be extremely important. And the other piece that will certainly be layered in here is artificial intelligence that will really be able to help us parse out a lot of these factors and determine where interventions and which interventions will make the most sense. So what is our call to action? Well, we all remember the triple aim, and that's we're going to improve the patient experience, we're going to get better outcomes, and we're going to decrease costs, and all of those things are interrelated. And that was brought to us by the Institute of Medicine around 2007. When it became clear that provider burnout was really also impacting our ability to achieve this triple aim, the clinician well-being was added to this. But despite the fact that we've known for well over 25 years, if not longer, that health disparities influence patient outcomes, it wasn't really until 2021 that health equity became part of the equation when it comes to achieving better health, an improved economy. And when we say improved economy, it's not just cost to the healthcare system, but it's also cost in terms of our patients and their qualities of life. So it really behooves us as pharmacists to keep this top of mind, that we can't really do what we do without having the tools and having the processes to address health inequities in our patients. And so ASHP last year issued a policy statement on pharmacoequity that had multiple different goals, and certainly raising awareness about disparities in clinical practice and the outcomes that they have, and how that compromises the ability to achieve pharmacoequity. So that's what we're doing here today, and recognize which the social determinants are that impact pharmacoequity, which is basically all of them, and how that will impact patient outcomes. And really what that means to me too is that we can't just ignore that they exist, but we have to, at least if we can just start by quantifying them and trying to set patients on a path to addressing them. We won't, Rome wasn't built in a day, as they say, but we all have to start somewhere. Certainly, I talked about advocacy for availability, pricing, insurance, all those things that promote pharmacoequity. But the other piece of this is also advocacy to make sure that pharmacists can practice under models that allow us to provide not just individual disease management, but comprehensive medication management that can really address pharmacoequity for each patient globally. We need to identify, advocate, and develop a workforce to identify and address threats, risks, and patient vulnerabilities as part of that comprehensive medication management. We need resources and technology, and some of these things, of course, are aspirational. We won't do it overnight, but knowing what we need to improve the care of the underserved populations is definitely a great place to start. And then to encourage the pharmacy workforce to identify and mitigate biases in their healthcare decision-making. And I think just being aware, as I talked about earlier, that can go a long way. I wanted to bring this study up for a couple of different reasons. Certainly, it's great to have a pharmacist disease management study published in the New England Journal of Medicine. But the other piece of this is that having a pharmacist meet patients where they are was able to result in improved outcomes in the reduction in systolic blood pressure management. And when you look at the achieving of the goal of less than 130/80, that was utilized in this particular study, you can see that the intervention was wildly, significantly better than what happens with just standard care alone. And for me, the message here is twofold. Certainly, pharmacist management of chronic diseases is always going to be superior to the current state of disease management because of the care and the knowledge that we bring to the situation. But I also think that understanding, meeting people where they are, knowing who they are as people, and being part of the community is really a crucial piece here. And knowing that patients could really develop the trust that they needed to improve their adherence to their therapy and not just their medication therapy, but their diets as well. So I think that this is really a great lesson for us to take forward when we think about pharmacoequity and, what some of the things are that pharmacists can do. Certainly, I mentioned it earlier, and this graphic is from the Get the Medications Right Institute, which I think has had a few different names over the years, but they really have been advocating for the utilization of comprehensive medication management, starting with identifying those medications that a patient is receiving that are not achieving therapeutic goals, and that we really need to have comprehensive medication management as part of the care of patients with chronic diseases in order for us to achieve optimal outcomes. And so certainly understanding that bringing social determinants of health and evaluation for health disparities into the equation is exceedingly important there as well. So, some of the potential roles, this isn't everything, of course, but, maybe some of the themes that came through while I was talking through the slides, as well as, some of the things that I've seen people talk about, what they've been doing is, again, be aware. Just think about what the circumstances are that your patients might be in, and what can you be doing to change them. Incorporating social determinants of health screening and documentation into your practice, going back to your institutions and understanding if it's even happening. I guarantee you there, on some level in the EMR it is, because coding for social determinants is expected to result in the ability to get greater funding. So it's really a priority from that standpoint. So whether or not that information is available and usable is, a different situation, but certainly is something to look into. I think community engagement is enormous, and my wonderful friend Vicki Powell has, made a great example of that and has talked about that in the lectures that she's given around diversity, equity, and inclusion. And I think that if all of us as pharmacists could find ways to do that, either on an organizational level with a professional organization, or as part of what we're doing in our hospitals and other places of employment, we need to get that visibility so that people understand that we're able to be part of the solution. I talked about advocacy, certainly education of ourselves, education of our students and our residents, and including our technicians in this process too. I probably wasn't clear enough on that, but I think that they can function in the same roles that community health workers do. And again, meeting people where they are and helping to get the message across, if that's what needs to be done, to better improve disease care. And then finally, research, which I'm going to spend the last little bit of time we have talking about the grant that the Research and Education Foundation has. But before I move into that, I just want to let you know that this is just the first of a series of programming that we're doing around pharmacoequity. On September 4th, we have 4 different speakers that are putting action into practice. And so they're going to talk about their pharmacy practices that are addressing health disparities. And then on September 17th, as I alluded to earlier, Dr. Udeby Eisen. He is going to be our keynote speaker. So we're doing the keynote last. It's kind of like eating the dessert first, but sometimes the order of things is not nearly as important as whether or not you're going to be able to get it. And I think it's really great for us to finish this off with what will be a very strong presentation by him and another speaker around achieving the vision of pharmacoequity. So I hope you're all able to join us for those two as well. And then finally, just wanted to give you a little bit of an update on this grant. So as I mentioned in the beginning of the presentation, we received money from Janssen, and part of those funds were to support education. And then the other part, $25,000 we have at this point, is to support research that evaluates the impact of pharmacist-directed programs that focus on addressing health disparities and achieving pharmacoequity and cardiovascular care. And so the grant application is just about complete, and you will get to see that will be sent to the entire membership, as well as some of our listservs as well. You don't necessarily have to be a member of the council to be considered for this grant, but that will be preferred. We're looking for individuals that do have research experience. So if you don't have research experience, but you have a great idea or you have a practice that's doing something, maybe that's an opportunity to reach out to a faculty person from your nearby School of Pharmacy to partner with you to do the research. It needs to be feasible within the timeframes that are listed there. So submissions are due in October. The grant period begins December 1st, and a final report will be due in August of 2025. So about a year from now. And then finally, we would like everyone who conducts this grant to have some knowledge around health equity and addressing health disparities, and be able to show us that you've had some training, be that on your CV, be a participation in this programming, or what could be employee-sponsored or employer-sponsored education, whatever it is. We want that to be documented, because I think it's important for people to really have a deep understanding of what these health disparities are. I could only scratch the surface for you today. I think once you read about it and learn about it and really understand the depth and breadth of just despair some patients have and difficulty that they have in being able to do some of the simpler things in life, and how that greatly can impact dealing with significant disease. I don't think something that we should take lightly, and I think you need to really truly understand that to be part of this, any research around this topic. So in conclusion, health disparities are complex, definitely, and each patient has their own particular set of circumstances, and adding on to that, whatever societal circumstances that they live in. So there's their biologic and their societal circumstances that combine to really create their unique set of health disparities. And we need solutions that require both systematic from a policy perspective, as well as patient level interventions, which pharmacists are really well suited to do. And we really need to take the lead in addressing health disparities and advancing pharmacoequity for these patients. So with that, I will stop, and we have about 5 minutes for questions or comments.
It says, Caitlin asks, is there data integrating precision medicine / pharmacogenomics into pharmacoequity?
Is there, I didn't specifically look into that, but there's definitely a piece, and thank you so much, Caitlin, for bringing that up. I think that should go on this previous slide here, where we talk about the potential roles for pharmacists. Absolutely. Individualized / precision medicine can help address pharmacoequity. I mean, it's not exclusively intended to do that, of course, but definitely I think would be part of that.
Okay, great. Thank you so much. Another big, Dr. Zammit, we are very thankful of you providing today's webinar.